Do you have my slides here?
Hello, everyone. We would like to start with the webinar now. My name is Dina Behram, and I welcome you to our webinar on QFR. We're happy to have in this webinar participants from more than 20 different countries. Today, the interventional cardiologist, Dr. Domenico Di Girolamo from Sant'Anna e San Sebastiano Hospital, Italy, will present our new solution, the QFR for 3D QCA-based FFR, and will also give a live demonstration of the software later. So now, Mr. Gerhard Koning, our product manager from Medis, will start and give you first some technical background information, and then Dr. Girolamo will take over. The webinar will take about 30 minutes. If you have questions during the webinar, you can use the Q&A option to write down your question. And then we will answer the questions during the webinar, or we will reply later via email. So let's start with the webinar now.
So welcome to this webinar. I just want to give some additional background information about QFR. And let's see. So the QFR is one of the parameters from QAngio XA 3D, our QCA software for the 3D analysis of the coronary arteries. And it's a QCA-derived version of the FFR value. Actually, we are using two images with at least 25 degrees difference in field of view. And from these images, we calculate the contours of an artery of interest. These contours will then be used for a 3D reconstruction of an arterial model. And we use that model, including a reference model, and the patient-specific volumetric flow rate to calculate the so-called QFR, quantitative flow ratio. So for this example, you see that the QFR value is 0.87, and the FFR value for this same patient is 0.85, so very close to each other. So how does it work in practice? This is the workflow. So you start with two angiograms of at least 25 degrees difference. These can be just normal angiograms using a monoplane system or a biplane system. From that system, we calculate the 3D reconstruction, and we calculate the anatomical parameters that are relevant for PCI treatment. Then in the next step, then we can calculate the so-called fixed flow QFR by the assumption of a fixed hyperemic flow velocity through the vessel. And then you have the first estimation of the quantitative flow ratio only based on the 3D reconstruction and a fixed hyperemic flow assumption. If you want to make that one more accurate, then you can also calculate what the actual flow velocity is for that particular patient by indication of the frames in which the contrast is getting to the start position and to the end position of the part of the vessel that has been analyzed. From that flow velocity for that particular patient, so it's very patient-specific, and the 3D reconstruction, you can calculate the so-called contrast QFR or CQFR. So for that, you only need use a rest angiogram, and no hyperemic situation is needed. So actually, the QAngio XA 3D software is the backbone for PCI procedures. It can calculate not only the anatomical parameters for the PCI treatment, but it can also calculate the functional significance of the lesions in that particular artery by calculating the QFR parameter. It will also give you optimal viewing angles for the treatment afterwards. And last but not least, it can also be co-registered in a next version, at least with the OCT or IVUS pullbacks of the same patient. So with this as a technical background, I will just give the word to Dr. Di Girolamo to give his presentation about the use of the software in a clinical setting.
Thank you, Gerhard. And okay, I want to thank all the participants to this webinar, and I will show you the clinical use of QFR in some settings that are very important in functional evaluation of coronary artery stenosis. I work in interventional cardiology in Sant'Anna Sebastiano Hospital in Caserta, Italy. And we had the chance to use this software several months, so you can show you some indication and some uses of this software. First of all, I want to recall the FFR, the use of FFR, the guidelines, the current guidelines. I apologize for the quality of this slide, but what is important here is the use of FFR. We can use it, we must use it to identify hemodynamically relevant coronary lesions when evidence of ischemia is not available, and this is a class 1 liver A indication, and 2 indications for revascularization, 1 positive and 1 negative. You must revascularize all the stenosis with FFR that less of 0.80, and you must not revascularize angiographically intermediate stenosis without FFR less than 0.18. These are now a contraindication to revascularize. These are the guidelines. But what's the actual use of FFR in Italy and Europe? We get the results of a survey from GISE, that's our society, interventional cardiology in Italy. Only 10% of patients with indication, according with guidelines, actually FFR evaluation. And in Europe, the average the patient is visual angiovarization. Why use so in few cases of FFR? The first problem is the cost. The second one is the invasive procedure. You must use guide wire, pressure wire. Mechanical characteristics are not so good, like the normal guide wire that you use in your PCI. You need drug administration, and maybe sometimes the operator is not confident with procedure, and sometimes not available in cath lab. Important issue, because I think that the cath lab today must have a functional evaluation tool, and it leads to times and reimbursement all around Europe. So some countries you get reimbursement, some others not. What is the ideal tool for in cath lab coronary reserve assessment? These are some points that I want to underline here. The tool must be not invasive, fast to use, and easy to embed in the diagnostic workflow. No drug administration. Get on not only the pressure, but coronary blood flow reserve indication too, and the cutoff threshold ischemic must be the same or nearly the same in follow-up. There must be an minimum increase of coverage, the first procedure assessment, and the cost, affordable cost. It doesn't exist. Okay. Now I will show you some cases in which we use the QFR to guide the procedure, and to show you how it's simple to do that, and the result of this functional approach to our cases. The first case is the patient with stable coronary artery disease and multiple stenosis. This is the ideal case to show how to use this functional tool for guiding revascularization. These are the characteristics of the patient. The procedure was done by radial access. It was done nitro before angio, as recommended by Medis. No adenosine. This is the basal angio. You see on the right side, the right coronary artery, you see a couple of lesions in the middle part of the artery and the distal part here. here and here. And on the other side, there is a left coronary artery. You see here a stenosis in the third marginal branch. Minor irregularity in the artery. Okay. This is the QCA, the basal right coronary artery QCA. This is done on 2 projections as Gerard showed you before. And you see here 3 stenosis, okay? And after the 3D reconstruction, here there is the model that was reconstructed by the software, and here you get the graph of the single stenosis. All the stenosis are the minimal lumen diameter and the length of the stenosis itself. This is the QCA of the marginal branch. Only a tight stenosis here, 62.9%. This is the graph. What to do? Imagine that you get no functional tool to evaluate the lesions. According to QCA, the narrowest lesion seems to be the ostial marginal branch. The tandem lesion in the right coronary artery are just over 50%. According to the angio, it looks reasonable to treat the marginal branch, leaving the right coronary artery untouched. Or you can treat the 3 lesions. But let's go to the QFR evaluation. This is the right coronary artery evaluation. And you see here that the evaluation was positive with QFR of 0.73. On the right side of the slide, you get the stenosis graph, and this is very important too. This is a virtual pullback, QFR pullback. So you can see here all the pressure drops related to it's only. This is very important, not only to see the functional significance of the single lesion, but to study it and to detect the length of the eventual stent that you can put there. So you see here that we have 2 drops related to 2 stenosis. Okay, let's go ahead. This is the QFR of the marginal branch. You see here there is only 1 tight stenosis, but with no functional significance. The QFR is 0.91. So you change your mind, not to treat everything, but I want to stand the first lesion in the right coronary artery, distal lesion, repeat the QFR, and eventually stand the second lesion in the artery. It will perform final, and I leave a very marginal branch. The stand distal coronary, the right with the rest for 3 points. The result just post stenting. You see in the virtual that dropped to the you get here only the first stenosis, and the vessel QFR was 0.8. What to do now? Approach is to treat the second stenosis, or to perform an FFR, or to perform a QFR with adenosine. But if you see this graph, you see that this is a study about adverse events at 6 months after FFR post-stenting. And you see that for the value of 0.83, you get 22% of events in the 6-month follow-up. So in this case, it's clear that you have to treat the second right coronary artery stenosis. And we did it with another stent here with a good result. And after we perform the final right coronary artery QFR, you see here that the result, the final result is 0.9. That means only below 6% of events in the 6-month follow-up is a very good result. And the virtual pullback curve is practically normal. This is another example that will point out the relationship between the contrast QFR or the normally used QFR with adenosine FFR. What we mean here that the QFR doesn't need adenosine for evaluation. That's very important because it reduces cost and speed up the procedure. This is another case with a very big male and was operated by thymectomy for myasthenia gravis. It was diabetes, only ischemic stress test, no myocardial infarction. This is the coronary angiography. You see here multiple lesions in the LAD. This was left dominant circulation. It's only lesions, multiple lesion in the LAD. Right coronary artery was not important. This is another view. You can see the lesions in the LAD. Okay, now we performed QFR and FFR evaluation in this case. This was the QCA, and this was the 3D reconstruction. You can see here the correspondence of QCA and 2D with the 3D reconstruction. And after, you see here the functional significance of each stenosis and the virtual pullback curve. Only the first and the third stenosis were significant with drop pressure, and the second one was not significant. These are the values of QFR of the single lesion. None of them was significant by itself, but altogether strongly significant. And this was done without adenosine. After we performed FFR, this is the basal FFR, that's negative. But with adenosine injection, the FFR becomes strongly positive, and it looks similar to QFR. So this is the representation of how to use QFR adenosine. Same result than ADO FFR. We treated the distal lesion with a stent. This is the result of QFR after stenting. You see here that you don't find any drop of pressure in correspondence of the treated segment, and you get here the first lesion. That is significant. The value is 0.83, and FFR basal was 88. And with adenosine, 0.79, that is borderline positive. So in this case, come of positive use without the same. Aggregation is okay. This is the last case that I want to show you. Another use of QFR in another setting. That's non-culprit lesion in acute myocardial infarction. You know that when you get a non-culprit lesion in acute myocardial infarction, the guidelines recommend to treat only the culprit if the patient is stable. And the non-culprit FFR is indicated in this case to understand if the lesion must be treated in a staged procedure. We have no data about the QFR use in the same setting. But you know that introducing a guide wire in the adenosine administration for non-culprit in acute MI might harm the patient. That is why we want to use QFR in the setting. And the QFR result may guide the revascularization to the true ischemic non-culprit lesion alone, saving time, contrast X-ray. This is the patient with chest pain, less than 3 hours, ST elevation to your leads, no previous angio. This is the coronary artery angiograms. There is a stenosis in the right coronary artery. This is the left. the culprit is the left anterior proximal part, and another lesion is in the circumflex, these marginal branches. Okay. This is the QFR acute phase, the right coronary artery. There is a tight stenosis here, but the QFR was negative. This is the marginal branch, strongly positive. This first bifurcation, first branch. The second branch was negative. Okay, after this QFR evaluation, the patient was stable, so we deferred the revascularization in the second procedure. In this procedure, we perform FFR2. This is the right coronary angiogram and the stage procedure. So you see here the lesion that seems less important than in acute phase. This is true. This happens often. This is the other lesion, good result on LAD. This is a functional study of right coronary artery. You see here the FFR adenosine was negative and the QFR was negative too. So we didn't treat this lesion. This is the marginal branch. The FFR was positive and was positive the QFR. So it was the same result in the naked phase. This is the virtual pullback curve here. And this is the QFR after treatment. We treated the patient with stenting and provisional stenting on the other branch. This is the result. It's very good. It looks similar to FFR with adenosine. And I don't show here the second marginal branch, but it was normal too. So this is a very good result. Here I want to show you what are the main studies ongoing on QFR. The FFR2 study, that's a comparison with FFR. Okay, that's a study about the QFR used to predict adverse events after stent implantation. Wi-Fi, it's very functional imaging, Wi-Fi, it's from Aarhus Hospital. And our study about non-culprit functional evaluation in STEMI patients. Now let's go back to one of the first slides in which I underlined some characteristics of an ideal tool for in cath lab coronary artery assessment, functional result assessment. Okay, the QFR is the answer. Okay, it's not invasive. Okay, it's fast and easy to embed in the diagnostic workflow. Yeah, our experience is yes. No drug administration. Yes. True coronary blood flow reserve, not only pressure. I don't know, maybe in the future. Cutoff for ischemic threshold and follow-up events equal. We must wait for the studies. Minimal increase of contrast and X-ray usage. Yes. Easy to repeat. Yes. Cost, okay, we don't know the Medis cost policy, but we hope that the cost will be much more less than the actual guide wire and equipment. Thank you. Did I finish here? Thank you all.
Yeah. So I see, Dr. Di Girolamo, there is
a question from the audience. Do you experience difficulties with overlapping of vessel angiogram? This is one of the pitfalls that you can have. And what we learned by using this tool is that you must do a very good angiogram. That's important. So brisk injection, avoid overlapping. Maybe that's a percentage of cases, maybe in about 3–4% of cases, which is very difficult to avoid overlapping. These are cases in which QFR is difficult to assess.
Okay, so I'm Gennaro Broia de Lucia, supporting the product for the Italian market. We will see now the workflow and why it's feasible to have an extensive usage of QFR in your lab. So let's start to see what we need to have the QFR done. So we need 2 angiograms orthogonal view with 25 degrees of minimum difference, acquired at 15 frames per second. So now let's start with the processing. Let's start with clicks. The first step is to co-register, to select the 2 telediastolic frame. So we do it on both angiograms, right? And then we proceed with co-registration of both images. We have to select the same anatomical landmarks in both projections. In this case, we use this bifurcation to perform the analysis. Proceed to next steps. We have to get the QCA indicating the proximal and the distal point, and then fix our analysis where is needed. We have just to check vessel boundaries and see at osseum level if everything is correct. We can proceed to the next step. Now we got already the QCA 3D. As a QCA co-registered in both reaction and at the anatomical 3D reconstruction with the diameter graph that indicate the whole disease, but also the singular lesion disease. On this side of the screen, we will see all the basic information for the stent planning. We have the lesion length, diameter stenosis, area stenosis, band angle, minimum lumen diameter, proximal, distal, minimum and maximum diameters. So these information are very important to plan the stent implantation and can be easily gained with 2 simple angiograms. We can see also a very nice 3D reconstruction of the coronary tree, in this case providing just this vessel. The clicks are almost finished. Let's take a look at the QFR results. We have just to check the control buttons for nitrate, administration, and vessel indication. The algorithm is adapted to each specific vessel segment. What we gain immediately is the QFR of the most distal vessel point, that is 0.53 in this case. Let's take a look now at the results. So we have QFR of 0.53 in the most distal part of the vessel. So here where the index is highlighted, but we can take a look at each lesion QFR weight. The first one that is indicated as 0.79, the second one that is indicated as 0.78, and then have this very important tool of digital pullback that can give you the exact weight of the pressure in each specific point you want to analyze.
Yeah, I want to show you an interesting application of this curve. And for example, you can use the pressure curve to establish how the length of the ventral standing is. If you look here, you must keep the boundaries, the edges of the stent, of the coverage of the artery, from the point in which the pressure stabilizes, like here, for example, the distal part, and here where the problem begins. So in this case, you have a 39.6 millimeter of stenting, and you are sure that you will cover all the functional drops of pressure in the coronary artery. So this is another application, another use of the virtual pullback curve, maybe about 40 millimeters. This is very precise. We found it very, tool is very precise. We must go, okay, just a bit more. This is important. And as another indication, if you have a diffuse disease with a spot, with lesions that are point in which the pressure drops, you can use this tool to understand how to put and where to put the stent, and how much of the artery must cover with the stent. Not from the QCA, but from the functional QFR curve pullback. This is an important way to use this pullback curve.
Okay, thank you very much, Dr. Di Girolamo. I also would like to mention that we are offering a 2-day course here in Leiden. And this course will take place, the next one, on the 24th and 25th of January. And you can register online on our homepage for this course. It also would be great, of course, to meet you at our upcoming congresses, for example, QCA in Paris, of course. And if you have any questions, you can contact us via the general email address sales@medis.nl. We are also open for any feedback. It would be great to hear from you how you like this webinar, and also in which topics you are interested in the future. So thank you very much for your time. And if you have any questions, please send us an email. Thank you very much and have a good day.
Thank you.
Bye-bye.
Bye-bye.
Thank you. Bye.